to start our conference now. Thank you. My name is Minghua Lu. I'm the Managing Director for eChina Health. We are China Healthcare Media and Independent Medical Education Organization. So we have agreement with AACR. We reached agreement in this February. So we started together AACR China. So we bring the AACR contents to Chinese community to serve the Chinese scientific community. So you can scan this ER code to subscribe the AACR China. Yeah, let me quickly for some. We have a conference guide, so you can scan this code. You can download or view the PDF version of the conference guide, which lists the agenda as well as the bios speaker. So we also have the AACR WeChat group for the in-person attendees. I think we already have close to 350 members. So pretty much most of the people in this room already joined the WeChat group. So we have also the code in the friend registration table. So if you're interested in joining the group, networking with the other attendees in the room. So you can join the group, or you can find one of us to bring into the group. Thank you very much. Now let me introducing the moderator of this conference, Dr. Li Yan. Dr. Li Yan is the Managing Director of U.S. Chinese Anti-Cancer Association and a veteran in the Global Farmer. Dr. Yan.
Okay, all right. It's great to welcome everybody to Chicago. And well, good evening, everybody here. But I understand that we also have people online in China. So good morning, China. It's really happy to host you all here in Chicago. And tonight is a China Summit and the China Night at AACR Chicago. It is organized by several organizations, Chinese Anti-Cancer Association, U.S. Chinese Anti-Cancer Association, which I represent, and of course, eChina Health, Minghua and his team here. And what is really, really, really important is this event wouldn't be possible to host if without the co-sponsors and the co-organizers. So I really want to give a shout for the co-sponsors. These are Hanshou Pharma, Henry Pharma, Li Di. Where's the Li Di? Oh, Li Di here, Li Di Biotech, and Chem Express. So thank you all. So first, I would like to invite Dr. Zhang, who is Deputy Consulate General of PRC in Chicago, to make welcome remarks. And I will give you one secret about Dr. Zhang, because I found out, I asked before the meeting, I said, what was your major of the doctor? She is actually doctor of economy from Nankai University. So welcome.
Thank you, Professor Li Yan. Distinguished guests, ladies and gentlemen, good evening. It's my great pleasure and honor to be here to attend this event. First of all, on behalf of the Chinese Consulate General in Chicago, I'd like to extend a warm welcome to all of you and congratulations to such a wonderful event. As we all know, cancer is the second leading cause of death worldwide and one of the major global public health issues. It has become a global consensus to jointly fight against cancer and strengthen international exchanges and cooperation in cancer research. So, as we all know that we have already observed Changes and turbulences have become the defining features of today's world, which I discussed with Dr. Li Yan before this ceremony. And so, while certainty was become one of the scarcest global resources, I think in current times, it is even more critical to strengthen international cooperation and exchanges in health. And I trust the event will be a great success and that all of the guests and friends in attendance will leave inspired to continue your work in the future because your work is very important and meaningful. Thank you.
Well, thank you, Dr. Zhang. Yeah, cancer has no boundary. It doesn't matter where you live in US, in China, anywhere else. We all face the same risk of getting cancer. So it's really critical for us to join forces together, fight cancer. Thank you. Now, I would like to welcome Professor Wang, Vice President of China Anti-Cancer Association. She's going to give us the opening remarks. Welcome, Dr. Wang.
Thank you, Dr. Yan. I saw so many people here. I feel very nervous now. Okay. Dear Mr. Minghua and Dr. Yan, Dr. Zhang, and ladies and gentlemen, good evening. Thank you for the warm invitation extended by China Health and the US CACA. It's truly an honor to be here on behalf of China Anti-Cancer Association. I must say, it feels like deja vu. 18 years ago, in 2007, CACA hosted the China Night during the 100th anniversary of AACR. Back then, we invited around 200 professionals to attend the event and prepared a buffet for the attendees. When I was introducing CACA, President Xi Shanghai was concerned that people might be hungry. So he suggested that everybody to be eating while listening. I quickly said, no, please wait for 10 minutes. Buffet isn't going anywhere, but speech might. So everybody laughed. And here we are, 18 years later. And I still asking for just 10 minutes of your time. Some things never change, except my opening speech is placed after dinner this time. It is so wonderful to see many familiar faces here tonight. Old friends who have been on this journey with me for decades. And to those of you I'm meeting for the first time, welcome. Let's make some new memories together. Now, let's talk about why we are here, cancer. It's a topic that knows no borders. Whether we are talking about worldwide efforts or the specific challenge and troops in China, cancer doesn't discriminate, and neither should our efforts to fight it. Over the years, we have made incredible strides, but there's still so much work to be done. And that's why gatherings here like this are so important. They remind us that we are not alone in this fight. Whether you are from China, the US, or anywhere else in the world, we are all on the same team. Cancer prevention and treatment is a global challenge, and China has been playing a significant role in this fight. I will introduce the highlights of the work which Kaka has done later. So, as we kick off tonight's event, let's celebrate the progress we have made, but also challenge ourselves to do more. Let's laugh, learn, and connect. In closing, I want to thank China Health and the US CACA again for the invitation and for creating this opportunity for global collaboration. And to all of you, thank you for being here. Let's make this exchange not only useful, but also memorable. Thank you and enjoy the rest of the evening.
Thank you, Dr. Wang. Now I would like to invite Professor Shun Lu from Shanghai Chester Hospital. Professor Lu is the chairman of Immunology Professional Committee of the China Anti-Cancer Association, and he's also the presenter of 3 oral presentations this year at AACR. So he's going to give a very brief opening remark.
Thank you, Dr. Lee. Actually, I don't prepare, anything for the opening speech. I'm a doctor. I'm a medical oncologist. I'm really honored to be here to participate in this China event and China Night. I really want to thank the CACA and the US CACA as well as Minghua organized this meeting. As Professor Wang already mentioned, we come here, we're humbling to learn something, but we need more collaboration with each other. I hope everybody tonight will be enjoy, and I just want to exchange your idea or something. The same goal for us is anti-cancer. Thank you very much.
Now we're going to invite Professor Ying Cheng from Jilin Cancer Hospital to also give opening remarks. Professor Cheng is the chairman of a small cell lung cancer committee of the China Anti-Cancer Association. Professor Cheng.
Thank you, Professor Lee. Good evening, my Chinese friend. I'm very glad to hear today for this important China Night meeting. It's a great honor to stand before you all, and I'm looking forward to insightful and discussion and exchange that will take place during the events. Thank you.
Great. So again, welcome. Now we're going to start our keynote speech session. And our first speaker is Professor Ying Wang from China Anti-Cancer Association. And her presentation is going to be current status and the challenge of cancer prevention and control in China. Professor Wang.
Thank you again. So this time, I'm very honored to introduce the cancer status, current status, and challenges of cancer prevention and control in China. So in the first part, I will introduce the cancer burden in China. Cancer is a major public health issue in China. It is the #1 cause of death in major cities and the incidence and mortalities keep rising. And according to the annual report of cancer registry in China, over 4.82 million new cases and 2.57 million deaths occurred in China in 2022. And this is the cancer burden in Asia in 2022. And everybody can notice that the incidence and mortality rate, China accounts for half of it. And this is the top 10 cancer incidence in China. For men, lung cancer ranked first, and for the women, breast cancer ranked first. For cancer mortalities, both men and women, lung cancer ranked first. And second part is the challenges of cancer prevention and control in China. The first challenge is aging of population. The aging population is a major factor in the high incidence of cancer in China. In 2022, the proportion of people over 65 in China has reached about 15%, higher than the world-recognized warning line of 7% of the aging society. The second challenge is the double burden of the tumor spectrum. In China, the incidence and mortality rates of liver, stomach, esophageal, and cervical cancers, which are common in developing countries, are relatively high. In recent years, there has been a significant increase in the incidence of colorectal, prostate, and thyroid cancers, which are more common in developed countries. The third challenge is the overall survival rate of cancer patients in China is relatively low. The main reason for the low overall survival rate of cancer patients in China is the poor treatment outcomes for common cancers such as stomach, liver, esophageal, lung cancer, and the rapidly increasing pancreatic cancer, leading to very low survival rates. Screening coverage is relatively low, and the patients are often diagnosed at the mid to late stage. And the overall cancer survival rate in China, fortunately, in recent years, it has increased. The data show that in the past 20 years, the 5-year survival rate for all cancers rose from 30% to 43.7%. However, it still remains much lower than that of developed countries. And the third part is cancer prevention control policies and key measures in China. So the first, the government pay a lot of attention on the cancer control. And in June 2019, the State Council issued the opinions on the implementation of Health China Action, which proposed to promote early screening, early diagnosis, and early treatment. By 2025 and 2030, the overall 5 survival rate should be no less than 43% and 46.6%. So the major measures that we have carried on is actively eliminate the controllable carcinogenic factors such as control of smoking, pollution, infection, and occupational protection, and food safety, and balanced nutrition, and moderate exercise, psychological counseling. And we also do some vaccination for the prevention of liver cancer and cervical cancer. And early diagnosis and treatment, timely intervention for the precancerous lesions. And also we promote the CACA guidelines to promote the standardized diagnosis and treatment. So in order to improve the 5-year survival rate. In the last part, I will introduce CACA's role in the field of cancer prevention and control. Founded in 1984, China Anti-Cancer Association is a non-profit and non-governmental organization. The headquarters office is located in Tianjin, and there are 820,000 members, and 31 provinces set up a local anti-cancer association. And CACA currently the president is Professor Dai Mingfan. This is CACA's mission and vision. I don't want to say very detailed. CACA and his branches host approximately 400 academic conferences, symposiums, and workshops each year. And the annual meeting of CACA is the largest conference in the cancer field, which was launched in 2000. Last year, the annual meeting, CCHIO, in conjunction with the 4th International Asian Oncology Society, was held in Xi'an. There was a total of 252 sessions, including 30 international sessions. It brought together about 5,700 speakers from China and abroad, and attracted 60,000 participants in person. The live broadcast reached 260 million views. CACA also launched the English journal named Holistic Integrative Oncology in collaboration with Springer Nature in 2022. It includes the guidelines, commentary, review, and original articles. HIO is an open access, peer-reviewed journal on all aspects of oncology and free of charge of authors. By now, 150 articles in 24 issues have been published. The current number of access is over 200,000 across 156 countries. The editor-in-chief is Professor Dai Mingfan. He's the president of CACA and the president of Asian Oncology Society and the president of a World Association for Integrative Oncology. He's a member of Chinese Academy of Engineering and international member of US and the French National Academy of Medicine. And this the associate editor-in-chief includes laureate and academicians from different countries. The international board of members accounts for 75% from 35 countries and regions. So welcome all of you to submit your papers. So this paper right now is free of charge for the authors. I think that's attractable. And we also, CACA also organized over 13,000 leading experts to develop the CACA guidelines for holistic integrative management of cancer from 2022 to 2023. It includes the 113 guidelines covering 53 types of cancer in the tumor chapter and 60 techniques in the technical chapter. The guidelines contain more than 10 million characters and were published in Chinese, English, and 10 other foreign languages. And in addition to composing the guidelines, CACA also put efforts to promote the use of them among Chinese doctors. We have organized a tour lecture with a total of 100 events held across China. In total, the number of participants has reached 2.6 billion on-site and online. The tour lecture of CACA guidelines covers 31 provinces across China. More than 600 experts tour a total distance of more than 135,000 kilometers. And we also promote CACA guidelines to local hospitals and more than 2,000 training courses for local doctors across the country. And we also promote CACA guidelines to universities. And CACA cooperated with 226 renowned universities across China and introduced the CACA guidelines to their medical schools. And we also promote CACA guidelines internationally. Since end of the 2022, CACA successfully hosted 17 international anti-cancer summits in collaboration with the global leading cancer organization. The total number of online viewers from 53 countries is 270 million. So that this China and the US Cancer Summit, we have 3 sessions. One was in 2022 and 2023 and 2024. And we also have the China-Europe Cancer Summit. And with Australia, Latin America, and Africa, Canada, and Singapore, Nepal, Tajikistan, and UK. So for this cancer summit, the visits reached to about 29 million. So that's the most, yeah. So we also have the cancer summit with OncoDaily and the SPCC, and also China, Japan, China, Egypt, and China, Latin America. So in 1995, CACA launched the National Cancer Week on April 15th to 22nd annually. It aims to encourage the public to adopt a healthy lifestyle and regular screenings. Various activities are organized by CACA across country, including free clinical consultation, public education, and survivor performances. Thousands of medical institutions and professionals participated in the campaign each year. In 2024, it attracted about 130 million people. Since 2008, CACA has participated in the World Cancer Day activity initially by USCC. CACA cooperates with governments, universities, institutions, industry, civil society organizations, and the media to carry out cancer prevention and control activities. And for the Global Cancer Week, CACA also joined them last year. One is with Latin America and another one is London Global Cancer Week. So CACA is very open to the world and collaborates with many world-leading cancer institutions and organizations. Currently, we have established a public partnership with 26 organizations and hospitals. And in November 2023, CACA launched the World Association for Integrative Oncology. In short, is WELL in Tianjin, China. And last year, on November 16, the first general assembly was held in Xi'an, bringing together over 120 members from nearly 70 countries and regions worldwide. So the board of directors consisted of 22 members from 19 countries and regions across 5 continents. Professor Dai Mingfan was elected as a president and me as a general secretary. This is the WELL's mission, the vision. If anybody interested in it, please contact us and welcome to join us. And in 2025, CACA will host 2025 CCHLO from November 6th to 9th in the beautiful city of Kunming, Yunnan province. The event will jointly organized by Yunnan Cancer Hospital, Kunming Medical University, and the Yunnan Anti-Cancer Association. Colorful city. Thank you.
Great, thank you. And I have to help Professor Wang to promote the annual meeting because I usually go there every year. It's just fabulous. It's unbelievable until you go there. Some of the sessions that are not like a scientific session, they're almost like a concert, right? So, and they have dancing, they have singing, they got everything mixed. Thank you so much. Yeah. Next, we're going to invite Professor Shun Lu, and he's going to do a back-to-back 2 presentations. Both drugs are discovered and developed in China, and both drugs are targeting the bigger family of EGFR members, but one with a small molecule target, a tyrosine kinase inhibitor, another one is with ADC approach. Nowadays, if we don't talk of ADC, you don't think we're talking about oncology. So welcome, Professor.
Thanks, Professor Yang. You know, thanks again, and good evening, everybody. Tonight, I will present 2 abstracts, which has already presented in AACR this year. Hopefully, you will be not boring. You know, the first abstract is actually Aumolertinib with or without chemo as a first-line treatment in local advanced or metastatic non-small cell lung cancer, which sensitive EGFR mutant we call the ANIAS-2 study. You know, here's my disclosure. As you know that EGFR mutant is very high incidence in East Asia, especially in China, around 50% non-squamous non-small cell lung cancer harboring EGFR mutant. Right now, the single agent third generation TKI, no matter Aumolertinib and Tagrisso, has other standard for first-line treatment. But we also want to further improve efficacy. So just recently, as you already know, that there's some combination strategy has already developed. Here, Professor Pasiani actually present FLORA-2 study. And also this year, you know, we just published the Minnesota results. So that it's already demonstrated combination, the TKI with other agents can prove the progression-free survival compared with the single-agent third-generation TKI. So actually, Aumolertinib, which is developed by Chinese domestic pharmaceutical company, we call the Hanson company. This is the oral third-generation EGFR TKI, already showed promising safety and efficacy in advanced EGFR-mutated non-small cell lung cancer, which already published in phase 2 data we call the Apollo study, as well as the phase 3 data, ANIA study. This year, I present actually phase 3 as 2 study, which further evaluate Aumolertinib combination with platinum-based chemotherapy versus Aumolertinib monotherapy for the first-line treatment in local advanced or metastatic EGFR-mutated non-small cell lung cancer. Quite similar study design like the FLORA-2 study. Actually we compare with the combination versus single agent, and but this is a totally China study. So the randomization 1-to-1, but the stratification factors actually only EGFR mutant type as well as CNS metastasis. Primary endpoint is BCA evaluated PFS. Secondly, actually including the investigator evaluated PFS and also BCA evaluated object response, disease control rate, duration of treatment, and also BCA evaluated PFS rate, and as well as OS and OS rate. We assume that actually the monotherapy progression-free survival around 18 months. So we assume that the combination will be 25.7 months. The hazard ratio will be 0.7. Here's the patient's disposition. Actually, the study from the August 11, 2021 to November 25, 2022. I should emphasize just that this period actually China experienced pandemic. So it's not easy. 624 patients across 60 sites in China were randomized. 1-to-1 randomized combination arm is 306 patients, and monotherapy are around 314 patients. Until data cutoff at June 18, 2024, still the 170 patients in the combination arm still ongoing, and the monotherapy arm is 122 patients. The major reason why discontinuation is both arms are progression. Here's the baseline characteristics, actually quite balanced between two arms. I should emphasize that mutation type for the exon 19 deletion, two arms both is 49%, and 51% is L858 mutation. And in terms of the baseline CNS metastasis in both arms, around 30%. So the drug exposure and adherence, actually, there were no difference in drug experience or adherence of Aumolertinib between two groups. And the chemotherapy did not reduce the use of Aumolertinib. Among the 304 patients, 88.8% actually completely 4 to 6 cycles of plateau-based chemotherapy, and the median duration with Pemetrux around 20 cycles. Actually, you were quite familiar with FLORA-2. Actually, the global data is only the maintenance Pemetrux around 6 cycles. So we are quite long, maintenance treatment. The main reason may be, Chinese patient tolerability is quite good. We always can tolerate it a lot. So, yeah, here's the primary endpoint. We reached the primary endpoint. The median follow-up, 23.4 months. Actually, median progression-free survival in combination arm, 28.9 months versus monotherapy, 18.9 months, hazard ratio 0.47, and the p-value less than 0.001, actually prolonged PFS around 10 months. And it's also confirmed by the investigator evaluated PFS. Combination arm, 28.4 months versus monotherapy 19.7 months, hazard ratio 0.55, and a p-value less than 0.001. We do the subgroup analysis. PFS benefit was consistent across all pre-specific subgroups, regardless of the gender, age, smoking history, EGFR mutant type, and baseline CNS metastasis, and equal performance. Here is the PFS by EGFR mutant type. In exon 19 deletion, the combination arm median PFS is not rich versus monotherapy 23.45 months and hazard ratio 0.41 and p-value less than 0.001. In terms of the 858 mutation, the combination arm PFS 23.6 months versus monotherapy 17.8 months. Hazard ratio 0.52 and a p-value less than 0.001. And it's regards of the CNS status at the baseline, the combination arm with CNS metastasis median PFS 26.3 months versus monotherapy 18 months. P-value less than the 0.001, hazard ratio 0.56, and regards of the without CNS metastasis population, median PFS in combination arm 31.7 months versus monotherapy 20.5 months, hazard ratio 0.43, and a p-value less than 0.001. And the response, actually the response in a combination arm is 93.2% versus monotherapy 87.3%, and the disease control rate in both arms 96.5%. The median duration of treatment in combination arm 27.6 months versus monotherapy 19.3 months. The overall survival data is still not much until the median follow-up 24.4 months. The median, but the statistical difference favored combination arm was observed. Actually, hazard ratio 0.44 and 95% confidence interval from the 0.31 to 0.64. And regards of a the safety data, the incidence of grade 3 AEs were higher with the combination than with the monotherapy, as we already expected. And a primary finding driven by the chemo-related AEs, you know, a lot of the hematological toxicity in the combination arm, the interaction of any agent in combination arm, 64.1% versus monotherapy, 25%, and a reduction of any agent in combination arm, 43.8% versus 3.5% in monotherapy, and the discontinuations of any agent, 21.1% versus monotherapy, 1.6 months. And the most common adverse events, that means more than 20%, usually the hematological toxicity, thrombocytopenia, neutropenia, and anemia. And in regards of this drug, the specific toxicity, that means the CPK increase in both arms around like the 50%, but I should say that the majority is grade 1 to grade 2. It's not need any, you know, reduce of dose. The more than grade 3 CPK increase in both arms around 10%. There's no this toxicity related deaths. So actually, I can get to the conclusion. The combination with llamatinib with platelometrics has demonstrated a statistically significant and a clinical meaningful improvement in PFS by BCAR compared with monotherapy, hazard ratio 0.47, 95% confidence interval from 0.37 to 0.60. The p-value less than 0.001 in patients with local advance or metastasis EGFR mutant non-small cell lung cancer. BCAR assessment median PFS 28.9 months versus 18.9 months. PFS benefits was quite consistent across all pre-specific subgroups, with notable effects demonstrated in both exon 19 deletion and L858 mutation subtypes. In terms of the exon 19 deletion, hazard ratio 0.41, and L858 mutation hazard ratio 0.52. OS data is still not mature, but a potential benefit was observed. The addition of chemo did not alter the Aumolertinib safety profile, and no new safety signals were observed. Furthermore, AE-related dose adjustment had not clinical relevant impact on the Aumolertinib exposure, and the adherence rate remained comparable between two arms. So I can get a conclusion. In China, Aumolertinib plus chemo offers a new first-line treatment option for patients with a local advanced and metastatic EGFR mutant non-small cell lung cancer. Actually, we already submitted the indication to Chinese FDA. So the second abstract which I present is early phase trastuzumab resection SHRA1811. This is the HER2-directed antibody-drug conjugate in advanced HER2 mutant non-small cell lung cancer. Update phase 2 results from the Horizon lung studies. As you know that HER2 mutation are commonly approximately 2 to 4% of non-small cell lung cancer, and usually associated with poor prognosis. The trastuzumab resection is a novel antibody-drug conjugate, compromise HER2-directed monoantibody and a cleavable tetratrope-based link and DNA top 1 inhibitor. The key design features including payload with potent cytotoxic and higher membrane permeability, and a charitable cycloprofile group between the link and the toxic, and a moderate drug to antibody rate around 6. So I conclude this phase 1 to phase 2 study to evaluate trastuzumab resection in HER2 altered non-small cell lung cancer in the registration phase 2 portion in HER2 mutant non-small cell lung cancer. The primary endpoint was met, and with objective response per independent review committee around 73.4%. The data cutoff at that time is July 14, 2024, which the paper already published in Lancet Oncology recently. Here, I present a data analysis after addition 6 months follow-up with focus for survival outcomes. So here's the study design. We do the phase 1 dose exploration as well as dose expansion. In the dose expansion, we follow the FDA and the Chinese CDE so-called dose optimization. We decide 4.8 milligram per kilo determined to be the RP2D dose. So then in the phase 2 stage, we do this single agent registration trials in China with local advanced metastatic non-small cell lung cancer, central confirmed advanced HER2 mutation, and failed to plateau-based chemotherapy plus PD-1 or PD-L1. So we're using the 4.8 milligram per kilo until PD. The primary endpoint is objective response evaluated by the IRC, and the secondary endpoint including ORR evaluated by the investigator, and the DCR, DOR, and PFS evaluated by the IRC. And OS. So the updated phase 2 data cutoff is December 14, 2024. Median follow-up is 14.2 months. Patients remain on state treatment 41.5%. Here is the baseline characteristics. The patient is median age is around 57.5 years old, and the majority of patient actually female and a good performance, and the majority of patient is never smoker, adenocarcinoma, I should say that the lines of previous treatment is around 2. And the previous treatment, including all the patients received the plateau-based chemotherapy and a PD-1 or PD-L1 treatment. And around 23.4% received HER2 ADC. The majority mutation type is YVMA, around 72.3%. We also do the explore the HER2 expression. Actually, even this is a HER2 mutation population, but generally a lot of patients has HER2 immunohistory is expression is negative. Here's the updated response. By IIC assessment, we get the response rate 74.5%, and investigator assessment 68.1%. The median duration of treatment around 10 months, and time to response around 1.5 months. And we do the subgroup analysis, nearly all the pre-specific subgroup analysis, including the sex, age, equal performance, brain mass at baseline, line of the prior treatment, and the patient prior received the HER2 TKI, and also the mutation type. Actually, all the patients can get a benefit. Here's the PFS data. The median PFS assessed by the IRC is 11.5 months, and PFS evaluated by the investigator around 12.5 months. So we also, regards of the PFS, we do the subgroup analysis, and nearly all the specific factors, including the gender, age, equal performance, at the baseline BMI, brain mass, and the line of prior treatment, and the prior HER2 TKI, and the mutation type. Nearly all the subgroup can get a benefit. I should emphasize that the most common mutation, like the YVMA mutation, actually the median PFS around 15.2 months. Here the OS data is not mature. The median OS is not rich, but you can see here that 12 months OS rate 88.2%. In regards of safety profile, actually treated related more than grade 3 AE 67%, and treated related dose interaction 38.3%. Treated related dose reduction around 17%, and treated related dose discontinuation to only 2.1%. There's no death treated related to the death. And you are very interesting, actually, ILD. You know, another HER2 ADC like Daiichi actually quite higher ILD, but this compound, you know, the ILD is only 8.5%, and the majority patient is grade 1 to 2. Only one patient experienced grade 3 ILD. So I can get a conclusion. Update analysis, trastuzumab rezetecan continue to show clinical meaningful efficacy, object response, 74.5% median duration of response, around 10 months, evaluated by the IRC, and the median PFS 12 months, and 12 months over survival rate 88.2%. Consistent benefit were observed across a broad range of patients, regardless of a prior line of therapy, even prior received anti-HER2 TKI, or at baseline BMS, brain mass metastasis, and across various HER2 mutations. Especially, I should emphasize that the most common mutation, actually we get to the PFS around 15 months. Safety profile was manageable and consistent with the previous reports. Our data support trastuzumab rezetecan as a new treatment option for patients with previous treated HER2 mutant non-small cell lung cancer. I also know that this compound should be approved very soon in China. And a phase 3 study is another way to evaluate this ADC versus plateau-based chemotherapy plus anti-PD-1 therapy as a first-line treatment for advanced HER2 mutant non-small cell lung cancer. Finally, I would like to thank all the patients and their families, all investigators and research personnel who conduct these trials, and also I would like to sponsor. Thank you very much.
Going to hold the questions when we have the panel discussion. Now, it's my great pleasure to invite Professor Ying Cheng to discuss the EGFR inhibitor. So Dr. Lu talked about the use of this EGFR inhibitor in the first-line setting, but Professor Cheng is going to move this further early into the adjuvant setting. So Professor Cheng, please.
Thank you. I'm honored to invited to present our trial on behalf of our investigators. I'm going to report Aumolertinib as adjuvant therapy in non-small cell lung cancer patients with stage 2 to 3B and sensitive EGFR mutation after completely tumor resection. It's randomized double-blind placebo-controlled phase 3 trial. Non-small cell lung cancer in stage 2 and 3 account for 35% to 45% of lung cancer. Surgery is the main treatment, but the post-operative recurrence rate is still high. Adjuvant chemotherapy increases 5-year survival rate by 11.6% for stage 2 and 14.7% for stage 3 patients, respectively. In adult, adjuvant Aumolertinib showed significant improved DFS for patients with stage 1B to 3A EGFR mutant non-small cell lung cancer. Notably, in adult, 69% of patients were stage 2 and stage 3A. 30% received adjuvant chemotherapy, and 64% were Asian patients. In Asian non-small cell lung cancer patients, EGFR mutation rate is 30% for 50%. This is much higher than Western population, with the 10% to 20%. Aumolertinib is a third-generation EGFR TKI. It shows stronger efficacy and safety in both EGFR-sensitive and T790M mutant patients. It's also been approved by NMPA for advanced non-small cell lung cancer. Therefore, we conducted a phase 3 study focusing on Chinese patients with high mutation rates and stage 2 to 3 who are recommended to receive adjuvant chemotherapy. Our aim is to explore whether Aumolertinib to be administered after adjuvant chemotherapy can further improve outcomes in those more defined populations. This is our clinical trial study design. A total of 48 sites in mainland of China participate. Patients were confirmed as stage 2 to 3B non-small cell lung cancer with sensitive EGFR mutation. All patients had tumor completely resected. Patient first finished 2 to 4 cycles of platinum-based doublet adjuvant chemotherapy, then randomed 1-to-1 to receive either Aumolertinib or placebo. The treatment will continue 3 years or until disease recurrent. The primary endpoint was BICR, assessed DFS. Secondary endpoint was investigators assessed DFS 2 years, 3 years, 5 years, and DFS rate, overall survival 5 years, overall survival rate, and adverse events. We planned to enroll 192 patients. DFS hazard ratio was 0.50. We plan 75 DFS events to reach 85% power. For April 2021 to April 2024, 114 patients were randomized to receive at least a dose of the aumolertinib or placebo. The two arms were well balanced in aumolertinib 19.4%, and in receive adjuvant chemotherapy, and in control arm, 96% receive placebo. But the data cutoff median follow-up was 27.6 months. 77 DFS events were observed. The median DFS for aumolertinib wasn't reached, versus 14.4 months for placebo. The hazard ratio was 0.17. 2 years DFS rate was 88.2% versus 40.6%. In the another on the DFS assessed by investigators, the findings was consistent with the primary results. The hazard ratio was 0.17. The patient with stage 2 and stage 3 EGFR-mutant non-small cell lung cancer patients, aumolertinib significantly improved DFS. In stage 2, median DFS wasn't reached for aumolertinib versus 27.8 months for placebo. Hazard ratio was 0.09. In stage 3, the median DFS wasn't reached with aumolertinib versus 11.3 months with control. The hazard ratio was 0.20. This slide shows subgroup analysis. Aumolertinib improved DFS in age, smoking history, and PS, both EGFR-L858R and 19 deletion benefit from aumolertinib treatment. The overall data wasn't mature yet. There are 2.8% deaths in treatment arm and 3.8% in control arm. The main reason of death were disease progression or other events, but not related to study treatment. For aumolertinib and placebo, grade 3 or high TRAE was 13.2% versus 7.5%. Dose reduction was 9.4% versus 1.9%. Stop treatment due to treatment-related AE was 0.9% versus 0. The most common TEAE were increased blood CPK, AST, and ALT. Most TEAE were grade 1 or 2 and manageable. The most common grade 3 or high TEAE were increased blood CPK and rash. In conclusion, our study showed aumolertinib had a significant improvement in DFS in Chinese non-small cell lung cancer in patients with stage 2 to 3B, sensitive EGFR mutations, and met this primary endpoint. Also, aumolertinib was easily tolerable, so suggesting this strategy is suitable for long-term application as adjuvant therapy. We found that aumolertinib improved outcomes in stage 2 to 3B EGFR mutant non-small cell lung cancer post-adjuvant chemotherapy and offer a predictor changing option for the defending population. I would like to thank our patients and their family and all the investigators. Thanks for sponsor Hansen. Thank you.
Great. Thank you so much, Professor Cheng. So now we can move into the panel discussion. And I would like to invite the two speakers to the stage, Professor Lu and Professor Cheng. All right. And also, very, very happy that joining us in this distinguished panel, we have Alex from Cleveland Clinic, please. And also a shot, Alex is actually running for the president of AACR. So everybody here who are members, just make sure you vote for Alex. We also have Dr. Passy Zhang from Dana-Farber. For those people who are too young to know Passy, he is the one who really discovered and elucidated the biology behind EGFR mutation in lung cancer and inhibitors. So amazing. We have Xiuning Le from MD Anderson. And we have Chen Bohan from Shengjing Hospital of China Medical University. And we have Xuening Yang from Guangdong Province People's Hospital. And I have Hui Li from Jilin Cancer Hospital. Wow. Start with Dr. Lu Shun, your presentation. So for this Aumolertinib, the EGFR small molecule TKI inhibitor, at least the two trials clearly demonstrated the efficacy. The first one is a NICE trial, the first one as a single agent. And now you just presented very clear efficacy. Well, I think the survival curve looks really encouraging, although it's not mature. In terms of its efficacy as a combination in the first-line setting. So I think one of the questions people are always thinking is, because you got the monotherapy efficacy, you got the combination efficacy. So when you see patients with EGFR mutations, how would you consider whether to give this particular patient monotherapy or automatically with chemo?
Okay, this is always the questions regards of the TKI. Right now we have the combination, no matter combination with TKI or combination with amivantamab. I know that in United States already approved by the FDA. It's China is a quite a similar situation, but we treated the patient right now always based two. One is so-called clinical characteristics, or we based on the so-called biomarker selected or the gene profile. So based on the clinical characteristics, we usually think that if the patient has a heavy tumor burden and CNS metastasis, we will need to quickly control the disease burden. So we will recommend, or at least the patient with good performance, we need to recommend a combination. But I really think that we need to really think to select it should be based on the biomarker. This is based on the biology or something. Right now, a couple of the studies is ongoing. As Pasi has already mentioned in the morning, one study actually I know that in United States in Memorial Sloan Kettering. So actually they are using at the beginning using the monotherapy, but using the ctDNA to evaluate. If the ctDNA is not clear, they will additional plus chemo or still using a monotherapy do the randomized, try to identify which patient can get a benefit from the combination. And also I do the study in China. It's at the beginning we're using the combination. Then if the patient get the ctDNA clear, we will using a single agent as a maintenance. But if the patient is still not clear, we're using a combination. So again, that I should emphasize, we still need the biomarker. Some study also show that maybe like the co-mutation, some patient like the P53 or something will be very poor prognostics. So we need a combination, but we really need a prospective study to confirm which is the best biomarker. But I believe that ctDNA maybe can help us to identify which patient can really get a benefit based on the biomarker.
Okay, that's really very, very exciting, because I think for everybody working in the oncology field for many years, we always try to stay away from chemo if all possible, right? So I will also ask the fellow panelists, maybe we could ask Dr. Han in terms of what do you think, how are you going to pick and choose the therapies? Do you agree with Professor Lu, or do you have other thoughts?
Yes, I very agree with Professor Lu, the opinion. I think the combination therapy is very useful in the tumor burden high patients or fast progressing before the treatment. In the past, we think the combination therapy is useful in the specific EGFR mutation, such as EGFR-21 point mutation or CNS metastatic the brain met. But in the NS2 study, we cannot see the same findings. The consistent benefits across the subgroup without brain met subgroup and EGFR-19 deletion seemed optimal benefit, different from the FLOWER2 study. We don't know the reason why in these two optimal subgroup exists the difference. I please someone else help me to explain the different result.
Yeah, that's very interesting. So maybe we could ask Pasi to see if you got any insights in terms of different EGFR mutations, they may respond differently.
So let me address a few things. So one was the question of combination versus single agent. And I don't think any of the trials today provide good guidance, either clinical or by molecular analyses, to help choose someone for single agent versus combination. So I agree with Dr. Liu that that is still a area that needs further investigation. In terms of the different EGFR mutations, in general, the L858R mutation is thought to be the worst of the two mutations. And it's nice to see that chemotherapy, both in the study that with Aumolertinib as well as in the FLAURA2 study, chemotherapy and EGFR TKI was better than EGFR TKI alone. So that is one, that could be one way you choose the combination, but it works better in both the common classes of EGFR mutations. In general, EGFR inhibitors are better, osimertinib included, inhibitors of the exon 19 mutant. That may be a biochemical, drug, mutant receptor interaction type of point than the L858R mutation. And that is still a mutation whereby one can think about additional EGFR inhibitors or additional approaches. Anyone else want to comment?
Yes, I was going to agree with what's been said, and we need data, right? But in the absence of data as clinicians, we have to do what clinicians have always done, which is use your clinical judgment, right? So if somebody is younger, you feel they can tolerate chemotherapy and they have a huge disease burden, as Professor Liu said, you use the combination. What I've done in some situations like that is I use the combination, but I don't do the maintenance pemetrexed part because that increases the toxicity significantly. So as it were, debulk with the combination and then I maintain them on osimertinib alone.
Okay, all right. Anybody want to talk about ctDNA in terms of both monitoring the disease relapse as well as monitoring the treatment efficacy and the clinical applications? I see Dr. Le, you are having the microphone.
Before we go there, I just want to make a comment on the combination studies start to see overall survival benefit, even in the all-comer total population. Mariposa reported out their final OS analysis, and FLAURA2, really the hazard ratio looks so promising as well. Maybe I'm too aggressive in the treating way. I felt that I almost want to de-escalate, more thinking along the line with Dr. Liu, in that because of the OS benefit, if the patient can tolerate, and then I almost always picking the patient who have very low risk factor to offer monotherapy. Before the OS data was apparent, so we were more thinking about who is high risk. Now OS becomes positive if both pan out. Then I almost think the reverse, that who is low risk that can actually derive enough benefit from monotherapy. I think Dr. Liu and the Helena Yu's trial will, from two angles, give us that answer sometime soon.
Okay, that's great. So hit the tumor really hard and then de-escalate. Okay. Anybody else in terms of a combination versus monotherapy? Any comments about using ctDNA?
I want to introduce myself first. I work in Professor Cheng's team as a molecular pathologist. Actually, I also do the basic research and the translational research. For the ctDNA monitoring, I think it's a very hot topic because the Adora and the Nature Medicine magazine just released some very important data to show the MRD is a prognostic factor. It can predict the disease recurrence before at least 4.7 months. But for predictive biomarker, I think now, like Dr.
Yilong Wu, he mentioned the like a drug holiday. So basically, for the MRD, predictive is how to let the patients get a holiday without using the continuation of the drug. And for the how to guide the therapy, I think it's still searching, because we know even for the targeted therapy, we didn't have too much driver mutations. So if we find some mutations in blood, can we guide people to use the targeted therapy? Even in tumor tissue, we don't have too much choice. So I think for the predictive biomarker for the therapy, we need more research. And for this this study, I think for the Aumolertinib, my point is we always welcome more options for the drug or for the regimens, because for Chinese patients, we need more drugs affordable, available, and less costly. And for the second, I think people need adjuvant therapy very much. We know osimertinib is the only one. But in clinical practice, I participate Professor Cheng's weekly consultation, clinical consultation. So a lot of patients, they eagerly looking for the adjuvant therapy. They are so worried about stopping the treatment. And this drug has less side effects, so I think it's a good choice. But I do hope, because this study, the confirmative test L858 and 19 deletions. So I think it's suitable for the rural patients. They didn't need a fancy NGS. It's so costly and need a high technique. But I do wish we can do the MRD to monitor. It's not talking about the adjuvant therapy, but we need to discuss how long the adjuvant therapy will last. So MRD maybe help us to find the answer. Yeah, that's my opinion. Thank you.
Okay, great. So I think that's, go ahead. Yeah.
Okay, I maybe add some of our experience, some of our study, but maybe just because I remember that the last year when the Flora 2 published and complete with Dr. Yilong Wu's editorial in the New England Journal of Medicine, there's with investigation collected the opinion from the doctors and the patients. Actually, for the combination with chemotherapy, the patients, I think they value the prolong of the survival, but they are worried about the long-term use of those chemotherapy. So many patients will still choose monotherapy. And the second one is that we published a drug holiday study in the JAMA Oncology last year, that those patients with major response, and we use if the patient have a ctDNA negative, and usually we have used a local consolidated therapy. This patient, after that, the patient can have de-escalation, though we call it adaptive therapy. We will stop the drug and use ctDNA for monitoring. If it's positive, then we'll use the drug again. And in this study, we show that the patient, many of the patients can have average about more than 1 year of free of the use of this drug. I think this can maybe have some this is a small study, but I think it gives us some information that some of the patient can de-escalation. They don't need to accept this chemotherapy or continue use drug because this drug have some long-term, I think, toxicity.
Great. Yeah. So so sounds like ctDNA is being implemented at least in an exploratory fashion in the clinical practice. But well, I guess we all hope that we will see large size prospective clinical trials that will provide hard evidence, because I heard at least several panelists that they're still waiting for such data to provide clear evidence. And I think we also touched the base in terms of how long you're going to treat these patients, right? When are you going to stop? So we talk about EGFR inhibitors. What do you think about immunotherapies, for example? How long are you going to treat a patient with immunotherapy? Will ctDNA also provide a similar evidence to support? It's a different beast. So how long to treat and when to stop? Or you just treat until disease progression, whenever the patients are tolerating?
Well, the question is immunotherapy.
Immunotherapy.
Yeah.
We're just talking about immunotherapy.
Yeah. So I think similar to the previous discussion, it's all about data, right? So most of the clinical trials, obviously, it was arbitrary. We stopped at 2 years. And so going beyond that, there are a few studies that looked at stopping earlier. So there was one that looked at stopping earlier versus 2 years. Earlier didn't seem to be as good, not a robust randomized prospective trial, but they analyzed and so on. So at this time, we need more data, right? Obviously, going beyond what the data suggests, the danger is that the toxicities are very idiosyncratic. So you could get severe IRAEs, even if somebody has been getting treatment for 18 months and so on. And also they are expensive. So in my view, until we get additional data, we just have to go with the data, which is, you go for 2 years in patients where the disease hasn't progressed. Yeah. And the easy way out for us in the US, if you go beyond 2 years, insurance won't pay anymore. So you have no choice.
What about in China, where PD-1 is pretty affordable?
But it's the same, actually. We should order recommendation based on the data, actually evidence. So right now, but only one is actually the controversial is like the early stage. Right now, the later stage, I totally agree that only 2 years duration of treatment. Then with earlier phase, earlier stage, it's controversial, It's if the new adjuvant, right now the Checkmate 8116, actually the only 3 cycles of new adjuvant, it's already OS benefits. So we really needed to think it over. If the new adjuvant get a PCR, is it necessary to the additional 1 year immunotherapy maintenance or not? This is, that it's controversial. So, that this is, we still need more data comparable with the preoperative new immunotherapy versus new adjuvant in PCR patient. Otherwise, that in early stage, 1 year, it's enough. But this, for the PCR patient, is it necessary, to still use the maintenance of immunotherapy? I think that we need more evidence.
Anybody else? Any thoughts? Additional thoughts?
I think it's for the advanced non-small cell lung cancer immunotherapy, 2 years is not enough because the Keynote 024 study, after completion of 2 years treatment, a lot of patients recurrent within 1 year. I noticed this phenomenon. Another reason is the progression for survival in the PD-L1 high progression patient. 5-year PFS rate is only about 10 to 20 rate. I forget the correct number, but even in the high progression PD-L1 the expression group, the cure rate is very low.
For PD-L1 greater than 50% for the Keynote 001, 5-year survival is around 20 to 25%. Right, but we're talking about OS, right? So we're talking about the long-term benefit.
I very important pay attention to the PFS. If the 5 years PFS rate is very low, we the OS rate is not very high. I think cannot transfer PFS rate low and OS rate high. I think so you can check the PFS number rate number. I think Dr. Yeah.
All right, great. Well, thank you. So last question. We today, oh, yeah.
Okay, so this is a wonderful opportunity for me to ask a long-lasting question for me. I always wondering why the mutation in lung cancer, for example, is so high, the accident, the rate of mutation is so high, focused on a couple of mutations. One is 858, another is Delta 19, right? So for me, it is incredible why the mutation, theoretically, it is from a random, a damage on the DNA, right? If you agree that the mutation is from a random damage from DNA, so why the mutation rate is so high only on these two sites? This is, I asked many people, nobody can give me a satisfied answer. So since today we have, so are you?
Don't know.
So first
you
of all,
you are promoters this mutation.
So first of all, mutations are happening not at random.
Yeah, why?
So for example, so we have a TCGA, and then the conversion is much harder than the transition, if you remember your genetics. And then within those transitions that's happening easier, there's a secondary, basically the whole genome also have the mutation propensity. For example, we all know that a certain tumor have APOBAC signature, so that's predispose the tumor. And then there are certain germline predisposition for DDR pathway. So first of all, mutations in our somatic somatic cells are not at random. Secondary, I think there's a huge selection, bias or ability, right? So the survival, if we do the BAF3 independent assay in the cell dish, the ability for a deletion 19 classical 946 to 746 to 750 deletion, the ability for that cell to grow is quite different than a 709 mutation, and also different than some of the compound EGFR mutation. I agree with the panel that we do not know exactly why, but I think layers of knowledge need to be built up so that we will try to understand more.
The only point is if you agree or not, the damage is random. Because this is because of chemical damage or the physical damage, and on the whole genome. Why the damage only pick the same point? This is my question.
So Charlie Swanson had a recent Nature paper also talking about the environmental impact to EGFR mutation, especially in Asian household. I think that will be a really good read.
Very, very good question. Yeah. So really, we talk about a lot of topics in terms of, how we're going to treat patients who is currently available modalities and the treatments and the therapeutics. But looking forward, let's go back to at the beginning. We always try to see whether we could get rid of chemo, right? And for patients who don't have EGFR actionable EGFR mutations, so you cannot use EGFR inhibitors. What do you think is the future for these patients to eventually get a regimen without chemo? Is that going to be pretty near future, or is it going to be we have to wait still for a long time?
Well, we do already have non-chemo regimens. We have single agent anti-PD-1 or PD-L1 inhibitors, or in combination with anti-CTLA-4 inhibitors, which in patients that don't have driver mutations but have expressed PD-L1 or high PD-L1, these are very effective therapies and can last for a long period of time. So the current immune checkpoint inhibitors don't work in EGFR mutant cancers, but it doesn't, I don't think, exclude the possibility that future immune approaches, whether it be cellular therapies, vaccines, other things that we haven't even thought of yet, could work in that patient population. I think remains to be evaluated and seen.
Mm-hmm. What do we think about bispecific antibodies, for example, VEGF plus PD-1, etc.?
Well, there's a lot of interest in that space at the moment, and some encouraging early clinical data, and we'll see where that ends up.
Okay, great.
More data is needed for sure.
Yeah.
I think, cancer cells are complex, heterogeneous, and so on. And what we find is that just go by the molecular characteristics and so on, you're going to be able to treat some you can't treat. Also, for the foreseeable future, we are not curing cancer. We are turning it into a chronic disease. So my personal belief is that we are not going to get rid of chemo. It's going to have a role at some point, because if we are not curing patients and they are living longer and so on, we are going to have to cycle with chemo and so on. And I think in lung cancer, we've been spoiled, right? We've had all these targeted therapies, so we don't like chemo. It's 2025. If you go to the colorectal space, they still cycle chemo like crazy, right? They are doing FOLFOX, FOLFIRI, and so on and so forth. And so we're going to have some of that. Obviously, one advance is antibody-drug conjugates, which are really chemo, just that we are delivering it differently. Right? So in a sense, even if we got rid of classical chemo and we didn't use irinotecan, but you use an ADC with a topo-1 payload, well, that's chemo.
Targeted chemo.
Targeted chemo.
Yeah, I agree that Pasi and Alex comments, actually, we call it targeted chemo, call it smarter chemo, whatever you call it. But additional to their comments, I should emphasize that may be interesting as regards of your questions that in China, the AK112, the VEGF and PD-1 biospecific, right now the PFS, the difference, but right now the first interim analysis, actually the OS not get the statistically significant. That makes the stock market, summit, dropping out quickly, But it's controversial. It's awaiting the more data, the mature data. But at least I should say that, we already, in lung cancer community, I already explored a lot of success with so-called chemo-free regimens, regardless of the PD-L1 expression. Right now, we know that PD-L1 high expression, monotherapy is okay. But also, we should right now explore to the so-called PD-L1 low expression or even never, negative patient with so-called the cold tumor. Can we still some new target or new modality? In the future, I mean that the PROTAC technology as well as tumor vaccine, and right now even in CAR T, I have already do the study for GPC3 CAR T in lung cancer. We already have the patient enrollment. So hopefully we in the near future, even in this solid tumor, we can get some data without chemo. I mean, that's, and also like the ADC, RDC, PDC, whatever you call it. I mean, that's, we're really in the near future, we can imagine that, lung cancer become the chronic disease. So the 5 years of a median 5 years survival, like the 5 years, it's okay. I mean, that's so the long term, a lot of the new modality will be developed. A lot of here, I mean, that audience, that is formed pharmaceutical company, you have a lot of new technology. I'm sure that in the near future, we will realize our dream, chemo-free in lung cancer.
And Dr. Yang talking about remove of chemotherapy from, I think, the perioperative therapy. I think they are it's a parallel trial with Cheng A16. They use PD1 plus CTLA4 in the neoadjuvant setting. It looks that in that study, I think it's still promising. I think that means that they don't need to use chemotherapy. But I think maybe don't be in a hurry to remove chemotherapy because we have published a model based on the CTON 1104 study that trial, of course, that tries use definitive as an adjuvant. In that model, that's if the patient with RB1 mutation, then they will not benefit from EGFR-TKI, I mean, gefitinib. Though this is it's just like non-randomized, just select the patients, only part of the patient intended is try in the study. But in our experience, yes, most of RB1 patients even were not very effective in even osimertinib. So I think that even those patients with driver gene mutation may have part of the patients will benefit from chemotherapy. And so, and another thing is that immunotherapy may not, that's less toxicity, may not less toxicity, because some of the adverse events in after immunotherapy, their adverse event will be last long for life. I think maybe about 20% of this will never come back. That's like, especially those endocrine toxicity.
About chemo-free, Professor Cheng Ying just published a paper last year about the PD-L1 low expression non-squamous non-small cell lung cancer. We did the big panel next generation sequencing, and by the algorithm calculation, we developed a score called ISAC score. by the scoring the patients, we find some people can get benefit from the chemo-free, but it's a retrospective study, so we look forward to the prospective study. But at least it gave us a hint, maybe in the future, by the rational or specific sensitive biomarker, we can make some portion for patients get chemo-free. Yeah,
great. Well, thank you so much for all the panelists. And no more comments, right? Okay, great. Thank you so much. I mean, you're not only for taking time out of your busy schedule during AACR, joining us, and also for all the work you are doing, pushing the lung cancer into a chronic disease. So thank you so much. I was told online there are more than 10,000 people viewing, watching this event. So, now we're going to move on to our next session, which is really, really important. We talk a lot about clinical trials, right? But one thing is really critical in my experience of running clinical trials. One thing that always stops or delays clinical trial starts, which is drug supply logistics. If you don't have a drug, you don't have a clinical trial. So our next speaker is Larry, who is from Advanced CTS Corp. He's going to talk about how to make sure you don't screw up your drug supply for clinical trials. Larry.
Hi, thanks for Dr. Ying. Yes, because I only have 5 minutes, I'll try to finish as soon as possible. So, yeah, our company is ACTS, is Advanced CTS. CTS stands for Clinical Trial Supply. In Chinese, it's 临床供应链. As we all know that the clinical many steps are involved in the clinical trials, like clinical operation, central lab, statistics, and analysis. Among them, some people may don't realize actually they call CTS, clinical trial supply, 临床供应链, or in the field we call drug depot, just like Home Depot, okay, to handle the clinical trial drugs. This is very, very important when you do clinical trials. And that including, oh, this one, sorry. Oh, this one. Yeah. Let's see, what's sponsored. Okay, so including storage, labeling, packaging, distribution, return destruction, and importing and exporting for global trials. And traditionally, as we all know that when you have trials, the sponsors outsource the trials to a CRO, okay? But actually, in the US or even in the world, most CROs, for example, in US, Quintel, Syneos, LabCorp, actually, they don't have the drug management facility. They outsource to third party, okay? And they manage the third party, okay, to finish the clinical trials. This is a traditional model. And as we are back to this one, actually, that's not optimal model. Optimal model would be a sponsor, okay, when you do clinical trials, you ask, for example, clinical CRO, you do your work, okay? You do a clinical operation for the drugs, handle management. You ask the professional clinical trial drug management company to do that directly. In that way, it'll be a more transparency, as I showed in the traditional model. You see the shape. It's not that, okay, less transparency, and also, especially to Chinese pharmaceuticals, it's less communication efficiency, okay? That would include definitely results lower, okay, operation efficiency and increase cost. I'll back to this one later. So this is, okay, just again, it's including storage, labeling, packaging, importing, exporting, transportation, and translation and randomization, double blending, okay, everything. And when the site is already recruit subject, then you need to distribute the drugs into the site under absolutely time-controlled conditions. And ACTS is called a one-stop service clinical trials. As I don't know how to see here. Oh, okay. Actually, in addition to handle clinical trial drugs, and we are also a registered drug wholesaler and a medical device wholesaler. So, for example, when the client has the drugs ready, then we need to, for example, okay, import from China to US to Europe. Okay, there's a Chinese customer, US customer, FDA, USDA, everything, all the documentations. And compared to R&D sourcings, for example, when you do a combo, PD-1 plus carboplatin, whatever, okay, that's you need to have a drug sourcing drug supplier to provide that, okay? Okay, then this is our warehouse is located in Central Jersey, close to Princeton. I'll pass this one. So we are New Jersey registered drug and medical device wholesaler. And we also register with the US FDA under the FEI numbers. And we also register with FDA database. And in the past years, we have successfully completed more than 50 global trials, including US, Canada, Europe, Australia, Taiwan, and South America, including Argentina, Mexico, Guatemala. And another credit we have is actually we also passed the EU on-site auditing. We call a QPD, QP declaration. Everyone, you know that actually EU is more restricted, difficult than FDA. Yeah. Okay, so this is our facility in New Jersey. So our total area is 10,000 square feet. And the lower one just shows our backup generator. It's 1.5 million kilowatts. And ambient room, operation room, cold room, and storage room for freezer contains -20 and -80 freezers. And security monitoring system, and of course, as you know, that's a temperature humidity monitoring system. So anyway, in conclusion, this our new facility is absolutely on the same level with the top players in the field in the U.S., including Catalan, Fisher, Almac, PCI. Okay. So I'll pass this one. So when you do a clinical trials, we now know that quality, 质量, okay? So our QA head, John Mandy, has about 40 years QA pharmaceutical experience in US, and including 26 years at Pfizer. And SOP, form, everything. Anyway, no mistake, okay? Keep clear record documentation for every step to ensure each step meets in compliance with FDA, EMA regulations. Okay. So QA. Then we have our facility. We have a data management, warehouse management, operation management, project management, and BDs. So anyway, so in this way, as you can see, so 专业的人找专业的人专业的事. Okay, as a professional,
so professional people doing professional things.
It's definitely much higher transparency and a higher efficiency, low cost. In conclusion, based on the 50 trials we finished in the past, I say compared to the other top players in the US, we can save client costs up to 40%. And the response speed and efficiency, okay? If I say 3 to 5-fold faster, I'm not exaggerating at all. Thank you very much.
You got more than 10,000 people listening to your talk online. So our next speaker is Shibo Tao from Sanyo Biopharmaceuticals. We are all interested in bispecific antibodies. And she's going to talk about super trailing antibody library. It's AI assisted. So welcome.
Thank you very much for the introduction. And my name is Shibo Tao, and I work for Sanyo Biopharmaceuticals as scientific director for our EU and US biologic service. And today I will be presenting about the core platform, which can provide a one-stop bispecific antibody solution for drug development. And this is an overview of our company, and we're headquartered in Shanghai, China, and we now have offices in San Diego and Boston. And here are a little bit of highlights about our current business and our platform and drug development related certification, as well as our team. So today I will be introducing for the following different aspects, or you can say it's different stages of the timeline when we try to develop a bispecific drug. So we have solutions for when you have a novel target, we can do monoclonal antibody discovery. And so when you get the antibody sequence and you consider about how to assemble them into bispecific, we can do the design and also lead assessment. And further downstream, we have the preclinical development capability as well. So let's first start with the antibody discovery part. We have this core platform called AI-enabled super trailing antibody library. So this contains a variety of different molecular formats, covering from fully human antibody library. And also for nanobody, we have this single domain antibody library with humanized skeleton. And we also follow the like natural feature of APACA libraries, APACA antibodies. So we have the one cysteine pair versus two cysteine pair here. And also recently we developed the optimal PI library, which means we optimize the sequence for like developability features such as isoelectric point and also some of the post-translational modification. And for animal immunization-based approach, we can do mouse, mouse, rabbit, and alpaca. And yeah, so our sequence design for the library have integrated the AI generating sequence. So with this as a larger scale, when we construct the library, we will screen and filter for those candidates that are, on the one aspect, they mimic the natural antibody amino acid distribution. And on the other hand, we also consider the drug developability feature as well. So when we finish the library construction, it becomes a kind of off-the-shelf products for our clients where they can start to screen their novel targets instantly. And since this AI-enabled and also off-the-shelf, we have been able to provide more molecule leads compared to traditional methods, and also greatly shortened timeline. We can finish the screening process in just 3 weeks. And we also bundled the phage display library with eukaryotic expression system, which means the validation of the molecule is more effective and close to the drug development requirement. So this is some of the technical feature and highlights. You can see the amino acid distribution in our library is close to the natural antibody. And we have the fully human skeleton as well to further shorten the engineering timeline. And this is some of the representative data where we can get up to a few hundred molecules for different antibody formats and different sub-library resources. And this is an overview of their general expression level, purity, and affinity. So in general, our platform have been supporting more than 100 antibody patent applications. And so far for the services we provide, the downstream pipeline have had 11 which reached IND submission, IND approval, and some of them already started clinical trials. And we also have supported academic clients in their publication in some of these top journal. So regarding the bispecific design, we also have this online platform, which is oneclickplus.com. This is completely free, and we have already built in all these combinations of bispecific antibody formats. So our client can choose by one click, and then the sequence input is also very convenient, and then you get the summarized report for download. And regarding sequence, this is also very helpful in terms of we have this FC variants database that we continuously update. So you can find all the, for example, antibody engineered version with different downstream functionality. So this have been built in into our online platform for sequence input. And so once you finish all this design, we also have the established platform for molecule assessment. So for example, in vitro efficacy, we have these different assays available from FACS, luciferase reporter assay, and audit cell assay. And we also have a large primary cell collection, which our clients can directly use in our projects. Regarding animal models, one of our primary focus is mouse tumor CDX model. So we have different cancer type tumor cell line, which we finished the method development of dosing and tumor growth timeline. So our clients can directly evaluate their molecule. And we also have some non-tumor animal models, and we conduct pharmacology and PK/PD as well. And this is some of the case study. If you're interested, you can visit our website for more information. And further downstream, we have this preclinical development capability as well, where we can do cell line construction and fermentation purification process, and also stability study. And we have a established quality system which meets both CN and US requirements. So for example, for industrial cell, we have these 4 host cells available for our clients to choose from, and the antibody titer can reach up to 12 grams per liter. And for fermentation process, we develop different culture medium screening and different other conditions. And we can also do 3-liter and 15-liter bioreactor condition testing. For purification process, we'll do these resin and filter screening, and for the optimize the purification process as well. And formulation process, we have a comprehensive drug stability and developability assessment platform. So we'll test different formulation in terms of buffer, pH, and other condition, and do the like temperature stability assay and all these force degradation conditions. So this is also supported by our comprehensive analytical platform to do these biochemical and physical assay. I think I have another slide, which is a summary slide, so it will be my last slide. the one before, thanks. Yeah. Yeah, so this is like a summary slide of our company, and yeah, basically lists all the number of IP patents we have published and submitted. And so far we have successfully delivered over 1,000 service projects to both CN and US EU clients. So in summary, I think if you have antibody research development needs, we can be helpful to your research and projects, and feel free to contact our BD team. Thank you.
Very nice, amazing. Yeah. It's amazing how fast you could develop antibodies these days. Our next speaker is Dr. Foreman from Numanos, and he's going to talk about really cool stuff, a clinical genomic AI foundation model. How are you going to use a model to really accelerate clinical drug development? So the title doesn't really tell much, so I guess we have to wait until the presentation to learn more. If we could get, yep, it's working. Maybe the deck is too long.
It's definitely not too long.
No, I mean the whole deck, because we put. Yeah, where's the point right here? So this is going forward?
Yes,
okay,
going forward.
Up, okay.
Down.
Okay.
All right, so thank you so much for having me. My name is Vitaly. I'm the co-founder and CEO of Numanos. I have background, I have my PhD from Columbia University. I then moved to Roche Genentech to lead one of their data science and biomarker discovery plans, specifically in immunotherapy resistance. And then I moved to lead translational medicine in Otsuka for some pharmaceuticals. And then started to establish, and this is where I noticed that there's a huge gap between drug development success rates, and specifically in the most expensive space that we have, which is clinical trials. And this is when we established Numanos. So what we don't do at all, and I think that's important for us to say today, is we don't do any shape or form of large language models, and we do not do any shape or form of Gen AI. So we've actually implemented a defense industry technology to understand how we can make clinical trials better. And this is the space. We believe, at least in my experience in industry, is that the biggest bottleneck is actually clinical trial development. It's the most expensive step, and this is where things usually fall at the end, and you have to be better than standard of care. So this is the space that we're tackling. And usually, the biggest excuse that I've experienced, at least in pharma, of why we haven't tackled this problem yet is because we don't have enough data. We don't have enough data quality. We don't have enough data quantity. Now, we believe in Numanos in something very, very different. And I have to say rather controversial statement right now. We believe that the majority of biotechs and the majority of large pharma companies today have access to data that can make them as profitable as Lilly in the next 6 years. Okay? So we believe that you actually have the data in order to make those clinical trials successful today. So in my experience, again, in pharma, in Roche Genentech at least, we were drowning in data. The problem that we could only use 0.1% of the data that we actually had access to in order to make those clinical trials better. And in order to actually fix this, what we did is we built from scratch, we utilized a defense industry technology that allows you to unify data in an unprecedented way that is not available anywhere in the world today. So we unify data into knowledge in a way that allows you to do the following. We can take today prostate cancer clinical trial data set and predict how patients on ovarian cancer would have responded on the same drug. And the way we're able to do this is because, again, we can unify data across disease modalities, indications, and data sets in ways that is previously unavailable. And the way we did this, we've actually partnered with Boehringer Ingelheim, and we build an immunotherapy-specific foundation model based on the data sets above. And what we generated is immunotherapy-specific foundation model that can predict how patients would respond to immunotherapy or why don't they respond to immunotherapy, and you can address those. Now, what we did in order to test it, we've actually used a renal cancer clinical trial to train this model, and we were able to predict how lung cancer patients would have responded to immunotherapy. Again, it's a cross-indication prediction, something that just doesn't exist yet, at least not in my knowledge. And you can see the results above. What you can see on the left side is the fact that 100% of the patients in that trial, there was no significant PFS between checkpoints and docetaxel, and you can see the p-value. But patients that we have selected, patients that actually benefited, you could have gotten the trial significant with reduction of 40% of the population. So what we are able to do today, and this is basically a prediction from renal cancer to phase 2 clinical trials, okay? This is a small sample size. So we were able to potentially save $12 million in costs, increase the trial significant, which was actually failed on PFS initially. Okay, this is extremely extreme capability that, again, according to us, doesn't exist anywhere else yet. And what we were additionally able to predict using very early clinical trials is that TIGIT is actually a very suboptimal target. And we were able to predict that ahead of time, and that TMB is actually a really terrible biomarker as well. Now, Beijing actually is one of the latest victims of TIGIT, unfortunately. And as I mentioned, we were able to predict that TIGIT is a really suboptimal target. Now, what we do today, the way we partner with our pharma and biotech companies, is that they come to us with very early on data, even preclinical, and we can help them choose which indication they will have the most success in. Also, what are the targets that they have that has the biggest indication expansion potential? And we can deliver results of up to 60x increased significance and up to 70% reduction in trial size and 2 years earlier to market. So the way we are, again, partnering, we come with the data usually, if especially it's in the immunotherapy space, and then we gradually can build these models for the company for internal usage. So we come, usually we help them design the trial properly with patient enrichment strategies, and then we provide those capabilities in-house. So thank you so much. If you have any questions, I would love to talk to anybody who is designing clinical trials. This is Vitaly Fomin at Numinos AI. This is my email. Would love to have a conversation. Thank you.
All right, we're going to invite Professor Wang to close our meeting.
Thank you, Dr. Yan. I think the people, much more people in outside than in the room. Anyway, I will give a summary of this or the summary of this conference. So ladies and gentlemen, dear colleagues and friends, on behalf of CACA, I would like to extend my congratulations on the tremendous success of this year China Summit and the China Night. My gratitude goes to China Health and the US CACA for your visionary leadership and unwavering commitment to fostering global collaboration. This event has once again proven to be an a valuable platform for exchanging ideas, strengthening partnerships, and inspiring future breakthroughs. Where tonight marks the end of our summary of summit, it is only the beginning of even greater collaborations ahead. Together, we will continue to bridge innovation across borders, advance scientific discovery, and improve lives worldwide. To all of our participants, your passion and dedication are what makes this community extraordinary. As you engage in the upcoming AACR meetings, I wish you insightful discussions, meaningful connections, and renewed inspiration. May the relationship forged here grow stronger in the years to come. Until we meet again, thank you. Safe travels and good night.
Thank you so much. Great. So this really concludes our meeting. And again, want to thank the organizers, Chinese Anti-Cancer Association, U.S. Chinese Anti-Cancer Association, eChina Health, and our co-organizers, Han Shen, Han Rui, Li Di, and Chem Express. So thank you and goodbye for people online. For people here, we have a cocktail and a reception outside. So we could network more. All right, thank you.